the next presentation. Nikola Kolev, physician-modified grafts, ProMax.
Hello, dear colleagues. My name is Nikola Kolev. I'm a vascular surgeon from Military Medical Academy. A bit of strange of a name for a presentation. I would like to show you a connection in between complications of endovascular aortic repairs may be connected with chemotherapy and about PMEG. So, these are my disclosures. We all know that the indications for PMEG is as a primary indication emergency patients, and when there is no other endovascular or surgical alternative. So, congratulations, Bulgaria, you're a PMEG heaven. So, based on our experience, we made a small classification about the modifications of the endograft, including type A modification for inclusion additional branches or fenestration or exclusion of the existing ones. Type B, longitudinal graft modification, transverse graft modification, and precannulation techniques. So, these are some from our type A modifications. These are from type B. I suggest you to remember this one. Type C modifications for temporary reduction or reduction wire technique, or the technique for permanent reduction, circular stitches. So, the question mark means we don't know, we should check. I would present you some cases from our practice. This is a 62-year-old patient with a history of coronary artery disease, carotid stenosis. The patient was referred to us from the oncology clinic. There was made a strategy for this patient. He was with primary adenocarcinoma of the cecum, and the strategy was first to do neoadjuvant therapy, surgical treatment, post-operative chemo or immunotherapy, and as additional finding during the CT, this one very good infrarenal AAA with the maximum diameter of 60 millimeters. First case, perfect. We did an initial EVAR, and the patient was referred to the abdominal surgeons. They did right hemicolectomy and the resection of the 6th segment of the liver due to the metastasis. The patient was asymptomatic for 24 months. After 24 months, due to right-sided hydronephrosis, the CT was made and the retroperitoneal formation, including the right ureterus, was found, followed by biopsy, excision, and ureterostomy. The patient was indicated for subsequently indicated for immunotherapy with pembrolizumab. So, after the 6 course of immunotherapy, the patient was presented into the emergency room with acute left lower limb ischemia. On the CT we provided, we find some parietal thrombosis into the main body of the graft, totally occluded left limb, and parietal thrombosis of the right limb of the main body. So the patients, that was during the night in the emergency operation. We did bilateral thrombectomy, we restored the pulse on the femoral arteries, and everything was fine for the next 3 days. On the third post-operative day, the patient was from all the time on the therapy with non-fractionated heparin perfusion. The patient developed a clinical signs of bilateral thrombosis. So, again, into the hybrid room. This is the initial angio showing total endoprosthesis occlusion. This is after several thrombectomies, and we saw that this parietal thrombosis, we tried almost everything, with double Fogarty catheter, with coda balloon to crack the thrombus and to extirpate it with Fogarty, but always the parietal thrombosis was persisting. So then we got an idea to do a re-EVAR, but we cannot only put aortic cuff into the main body because we have also parietal thrombosis into both limbs. So we decided to do this. We redirect a bifurcational graft, cutting out the shorter limb and placing it inwards into the main body just to have an inner branch endoprosthesis. So we did it. Typically, with implantation, we do it type of ballerina because the conic part of the main body to the transition from the huge to the two smaller lumens, we used it if is thrombus left to take this part of the endograft. So everything was perfect. We cannulated the other limb. We do the post-dilation. You can see where the inner branch starts, a little bit above. So everything was perfect. We restored a perfect pulse of the femoral arteries. We closed the right femoral artery, and we decided to make a left femoral interposium. Due to the problems about 45-50 minutes struggling with weakened wall of the distal left iliac artery, we made an angio and saw persisting dissections on the left iliac artery. So an idea came from my small talk with Professor Krasi Ivanchev in the past years. So in the beginning, the endografts were made with only one proximal stent attaching, and the distal part was surgically anastomosed with the femoral arteries. So that's what we do. We get one iliac extension, connect it with a dacron prosthesis, put it inside the delivery system, and implant it into the iliac and femoral artery. You can see the artery wall. It was disgusting, about 50 minutes of suturing and nothing happened. So we did only one anastomosis to the profunda femoris. The patient was discharged on the 10th post-operative day in good condition, with no decrease in the ankle brachial index, on triple therapy with aspirin, clopidogrel, and vitamin K antagonists. But the connection of the immunotherapy and parietal thrombosis of the implanted endograft bring a light in our head. So we did a research from our database, and that is not all. I will present to a 67-year-old female patient after radical hysterectomy and endovascular treatment of type 3 AAA. The control CT was performed in between 14th and 15th course of immunotherapy, and you can see in the descending aorta we have into the endoprosthesis of the descending aorta we have intraluminal parietal thrombosis. This patient was only on clopidogrel. We added apixaban and restored the immunotherapy. The next 73-year-old male patient with malignant melanoma and thoracoabdominal aortic aneurysm. Also, we did PMEG also fenestrated endograft with perfect postoperative period, and on the control CT we can see parietal thrombosis inside the thoracic graft on the level of superior mesenteric and on the level of the bifurcated graft. So the patient also was discharged on anticoagulant and antiaggregant. So the reported cases are demonstrating three major common features. First, all of the patients have aortic aneurysm and associated with active oncological disease. In all of the patients was used polytetrafluoroethylene-coated endografts, and the patients were on immunotherapy with pembrolizumab. So we then check the literature about the common cases all around the world. We have one article about cancer-associated thoracic aorta thrombosis in a patient, small thrombus in the ascendant aorta. We all know that the oncological diseases are increasing the thrombogenic statements, mostly for the venous thromboembolism, in some cases arterial, but there was never described parietal thrombosis into the PTFE endograft on patients with immunotherapy. So, in conclusion, PMEG is a viable endovascular options for emergency management of endograft thrombosis, particularly in complex patients with limited treatment alternatives. The presented cases suggest a possible association in between immunotherapy and thrombotic complication in patients with polytetrafluoroethylene-coated endografts, and further investigation is required to better define the interaction in between immunotherapy and endovascular prosthetic materials. So, in the spirit of the Balkanic endovascular course, we have a great panel. Dr. Nikola is the vascular surgeon that did the first PMEG in Bulgaria, and Dr. Todorov is the chief of oncosurgery clinic. So I would like to make the conclusions together with them and with all the floor. Thank you for your attention.
Thank you very much it's a very interesting presentation. In my practice, because I work in vascular field, and I don't see the change of the patency of the bypass I do in my daily practice, but it's interesting for endografts. It's very interesting. I don't see, only the first case was occlusion with a clinical presentation. The other one is only
asymptomatic, totally
asymptomatic. Yes, maybe the last two cases are because of the outflow. I don't see the iliac vessels. I don't see, because the thrombosis was in the main body, and if you don't have a good outflow, you can see this picture. It's not necessary to be oncology patient.
That was our first, because of this patient, he has only the deep femoral artery on the left side, but it has a good lumina and good collateral system. He had preoperatively 0.75 ankle brachial index. So in other two cases, the patients have no arterial occlusions up to the pedal arteries.
Yes, in my opinion, also, it's hard to say, is it the PTFE, is it the immunotherapy, is it the oncologic state in general with its hypercoagulable state. So it really needs more investigation maybe, because we also see some parietal thrombosis in regular cases without cancer. It's hard to say, but very good choice of to manage the first patient. Congratulations.
Thank you very much.
So let's go on with the program.
Coffee break.
Or coffee break.
It's time for coffee break, I think. Okay.
Okay.